My name's Dr. Ruth Potee. I'm a family physician. I work in rural Western Massachusetts, and I take care of brand new babies and people well into their hundreds. I take care of all diseases on the in-between. I'm board certified in family medicine, and in the last 3 years, I've become particularly interested in addiction medicine. I'm also board certified in addiction medicine. I began this work partly because it became apparent that other people weren't really doing it, and we were missing this actually huge number of patients who are really struggling, not just with an opiate addiction, but also with an alcohol addiction, that the rates of addiction amongst all of us range between 10 and 12%. Yet I learned nothing about this during medical school, and I learned nothing about this during residency. And the idea that I could be a practicing board-certified doctor and know nothing about a disease that affects 10 to 12% of Americans seems shocking to me. But that's the way it is. So I give these talks to high schools and to teachers and to parents and to communities, and I wanted to be able to give the talk to you today. So we're talking about the physiology of addiction today, and one of the things I'm going to say is what you're seeing is an article in Science magazine in 1997 that said that addiction is a brain disease and it matters. And at the time, this was really big news, and it was big news because for so long people have thought of addiction as being poor choices, a moral failing, bad genetics, bad upbringing. And in 1997, I was in medical school, so this was big news, and in fact, it continues to make headlines. Just this week in the New England Journal was one of the lead articles was on the fact that addiction is a disease, and it actually walks through much of the same physiologic descriptions that this original article did in 1997. So we're going to spend time talking about 3 parts of the brain, focusing on the reward center of the brain. And we're going to talk about the ventral tegmental area, the nucleus accumbens, and the prefrontal cortex. And one of the things that's most important to know about this is that this is the most elemental part of the brain. This is one of the most ancient parts of the brain. It's the part of the brain that tells you every day to get up, to find food, to find clean water, and actually to find a mate. Because although we all may think that we have a purpose on this planet of walking the dog and going to work and taking care of our kids, evolutionarily speaking, our purpose on this planet is to survive long enough that we can pass our genetic material on. So this reward center of the brain gives you positive reinforcement for making good decisions about food, water, and finding a mate. And the problem is, it is addiction that breaks this part of the brain. And it would be great if we were able to move what part of the brain addiction affects, but we can't do that. If it affected the visual cortex and people lost vision when they had addiction, or some other part of the brain, it would be a lot easier to fix. Instead, this most fundamental elemental component of the brain is damaged in a way that allows people to become very ill and to really, in so many ways, not be able to control their lives or their decisions. We're not going to spend time talking about serotonin, which is one of the neurotransmitters that you're going to see on the screen. That is a neurotransmitter that governs mood, cognition, sleep. We're going to spend most of our time talking about dopamine. And dopamine is the neurotransmitter that is interacting with this reward center. It gives you a great sense of euphoria, gives you a sense of pleasure. It's again this reward sense of I need to continue this behavior because this behavior is good for me. It's what allows me to survive and allows me to have a future generation ahead of me. It has 2 behaviors associated with it, and that is compulsion and perseveration. And I just want you to think about those 2 behaviors. It is very helpful to wake up every morning and be compulsive about finding clean water and nutritious food. You want to perseverate on finding a mate. You want to perseverate on surviving. So those behaviors, when associated with surviving, make total sense and you'd want them. But apply those 2 behaviors of compulsion and perseveration to the disease of addiction, and it begins to describe why it is that people can only focus on actually managing that disease, that it gets in the way of everything else, raising their kids, pouring a bowl of cereal, finding a job, getting to work, getting up and volunteering anywhere. Part of this disease is you only can think about actually acquiring this drug. There's some of us on this planet who have naturally high dopamine levels. If all of us are sitting maybe at 100, some of us just feel great every day. And that's partly luck and partly some genetics and likely some epigenetics or some environmental factors. But some of us are sitting with a dopamine of 108 or so. Some of us every day actually feel a lot worse than that. And I would argue there are some of us whose dopamine levels may be sitting at 85. And we know those people. They're sort of the glass half empty people. It's very hard for them to think that there's going to be a positive angle. So the way that it works with addiction is that when you are sitting at a baseline of a dopamine of 100, and then you find that perfect food that you really needed, that lovely June 20th strawberry. All winter long, you've been looking forward to that first fruit, and you've had actually no fruit for a long time. And you have that June strawberry with 27 different flavors in it. You get a spike in your dopamine. It might spike to 150. If you have sex, consensual sex, orgasm, things are great, your dopamine spikes to 200. And that's the way it's supposed to be. When you use cocaine, your dopamine may spike to 350. If you use heroin or another opiate, it could spike to between 500 and 900, depending on the purity. And if you use crystal methamphetamine, your dopamine levels will spike to between 12 and 1300. So that seems like a great idea then to use crystal meth, because who wouldn't want a dopamine level of 1200? So you all now see what happens to the dopamine in the brain when you're using cocaine or heroin or crystal meth or other drugs. And the question is, why aren't we all doing that? If you can have a spike of 1200 or 900, that seems like a great idea, right? But it isn't, because it's not sustainable. And we're going to dive in on exactly what happens to the brain that prevents this from being a long-term benefit to you and, in fact, causing tremendous harm to your brain over time. But we're going to spend time now actually diving in on what it is that happens to the brain that causes this spike. So all of what we know about dopamine involves three things. It's a little equation. It has to do with how much dopamine is produced, how many receptors are receiving dopamine on the other side, and then how many reuptake inhibitors there are, which are little vacuums that suck the dopamine out of the synaptic cleft. So I'm going to actually focus on two drugs, and I'm going to show you why it is you get these lovely dopamine spikes. So the way that cocaine works is cocaine turns off the reuptake inhibitor, so it turns off the vacuum that sucks dopamine out of the synaptic cleft. Consequently, you'll have a level of 350 of dopamine sitting in that active space. The way that opiates work is more complicated, and at the end of the day, through a mu opiate receptor, it allows the transmitter to produce more dopamine. So I've described an equation where three things can get adjusted. Cocaine adjusts one, which is turning off the vacuums. Heroin or other opiates does another, which is just producing more dopamine. But every drug or addictive behavior does something in that equation that alters the amount of dopamine that your brain is seeing. So the problem is that when you're having a dopamine level of 350 or 600 or 1200, the brain sees that volume and thinks, holy smokes, we have been on this planet in this form for 200,000 years, and there's nothing that should be giving us dopamine levels like that. There must be something wrong. I'm either producing too much dopamine, I have way too many receptors, or my recyclers are broken. I need to turn down the volume. I'm going to downregulate. I'm going to stop making dopamine. I'm going to get rid of my receptors on the other end so there's nothing to receive that information. And I'm going to increase the vacuum sucking dopamine out. That is the normal brain response when it is exposed to these spiking dopamine levels. The problem is then that if you started off with a dopamine level of 85, you got yourself to that lovely spike of 1200. But as you enter into the world of addiction, you're never going to see 1200 again. Your baseline starts to drop, and your new baseline is no longer ever back to 85. It actually gets down to 45 or 50 or 30 on bad days. Those dopamine levels, that is your new normal, your new set, are dopamine levels that really are not consistent with surviving well on this planet. It's hard to get out of bed. It's certainly hard to go to work. It's hard to engage happily with anybody. It's hard to find joy anywhere when you have dopamine levels between 30 and 45. And this is what happens, though, after exposure to addiction. And I think of it as being the time when the brain breaks. The good news about the brain breaking is the brain can get better. And we're going to spend some time a little later talking about how brains can get better. But for people to think that this isn't a disease like every other disease out there, knowing what you now know, knowing that this is a disruption in the transmission system, I need you to remember the way that all diseases work in the body. And I'm just going to spend a minute talking about diabetes. So with type 1 diabetes, the way it works is that your pancreas doesn't have the ability to produce as much insulin. And consequently, insulin is not going to the insulin receptor, and consequently, glucose does not get sucked into the cell. The way that type 2 diabetes works is there's plenty of insulin being made by the pancreas, but the insulin receptor gets broken. And with a normal pancreas, there's insulin, there's an insulin receptor, and it sucks glucose in. Now, that pathway that I just described looks a lot like the reward system in the brain, where something disrupts a transmitter, a receptor, or the reuptake of glucose. So again, a disease that everybody thinks is a disease, even though quite honestly, we can create a lot of the disease of type 2 diabetes. I mean, that's brought to you by bad lifestyle choices, eating too much sugar, being overweight, being inactive, having a lot of processed foods. But nobody sits there and blames and shames and incarcerates people with type 2 diabetes. Yet that's what we do when people get addicted to a drug and when that part of their brain is broken. You can Google any of this, but there's a lot of PET scans that you can see that show you what the brain looks like on drugs. And what you're going to see here is that there's a normal brain. That orange stuff is dopamine, and then there's a brain of somebody who's struggling with an addiction. And as you can see, there's very little dopamine that's happening in that brain. This is another PET scan where that middle column shows you a nice healthy brain. That's the control column, and you see lots of orange there, lots of active dopamine transmission. And then as you go drug by drug, you see far less in the way of any dopamine production. That top one is cocaine, the next one is crystal methamphetamine, the third one down is alcohol, and the final one is an opiate. And the interesting thing I would say about this is, first of all, there's very little dopamine in these brains where people are struggling with those substances. Alcohol still has some dopamine activated, and it's one of the reasons why so many of us are functional alcoholics, is people still get up out of bed and do okay. They sort of shuffle by in their lives until things really fall apart, until they get their third OUI and are locked up or their partner walks out of them. But the dopamine reactivity with alcohol is a little more subtle. So one of the ways that we can all work to help people not get the disease of addiction is to know the following three things, which is that there are three areas that really predispose you to having the disease of addiction. And I think everyone knowing that is the most important thing, and then making better decisions based on that information. So it's a combination of genetic predisposition, having early use or early exposure, and then the final one is a history of trauma, particularly childhood trauma. So the genetic component, none of us can control. That's just what we're given. The genetics, however, plays an enormous role in addiction. In fact, I would argue that there's no disease that has as much genetic predisposition as addiction. So 50% of addiction is genetic. And what that means is that if one of your parents is addicted to a drug, you have a 50% chance of acquiring that disease as well. And one of the things I say to parents all the time is, your kids would know if you had a strong family history of cancer or heart disease. You should let them know if you have a strong family history of addiction. Even if you yourself are in recovery, which is wonderful, it doesn't mean that genetic predisposition isn't there. It's still there. Our kids will make better choices if given the information that they need. So the other component that you see that will predispose you to a lifetime of addiction is early use or early exposure. And what we know is that addiction is really a developmental pediatric disease. If you have not started with an addictive substance by the age of 23 or 24, you will not actually have an addiction. That it all starts in that period of time when your brain is under development, when it's making decisions about what synapses to keep and which ones to get rid of. And so when you sit down with somebody who's struggling with addiction, you ask, what was your first drug that you used? Most often I'll say, was it marijuana, alcohol, or cigarettes? And when did you first use it? And I usually start, sometimes I'll say the number 12. And in a room full of people who really struggle with addiction, in fact, a room full of people who have been incarcerated where I've given this talk, I've said, what was the earliest age that you started? Was it 12? And every hand is in the air at 12. And then I start doing the countdown, 11, 10, 9, 8. Hands are falling, but I still am counting down in this room. 7, 6, and it's at the age of 5 where every hand is down. So that seems extraordinary that anybody could start drinking or smoking at the age of 5, but when you ask people what their first use was, it often can be extremely young. And quite honestly, 11 and 12 and 13 and 15 are young, because this is a developing brain that is particularly vulnerable to setting down grooved marks that predispose you to a lifetime of addiction. And what you'll see in the next slide is that if you actually start drinking, and drinking here is defined as 2 drinks a week. So I'm not talking, having a kegger on a Friday night. 2 drinks a week, and you start at the age of 15. 40% of those students will go on to have the disease of addiction to alcohol. If you wait and you start drinking at the age of 21, 7% go on to the disease of alcoholism. So that is an enormous difference. 40% at the age of 15, 7% at the age of 21. And that has to do with having a brain that is more mature, that can actually control the substance being in it. There's a reason the legal age of drinking is 21. So students today, and this is the most up-to-date data that we have, the number one drug of abuse for our students is, I think, what most people would think it is, and that's marijuana. And the second most common drug of abuse are the stimulants. And I'm going to spend a little bit talking about marijuana. One of the things I'm going to say is what's extraordinary about students today is that the drop in cigarette smoking has been extraordinary. We're at the lowest rate of tobacco use amongst high school seniors that we ever have been in history. And that has been a significant drop each year for the last many years. And in fact, we're at 5.3% with how many seniors are smoking right now, which is wonderful. It's a great public health advance that has been made. As smoking cigarettes has gone down, the use of marijuana has gone up. And one of the reasons for that is that there's a sense of decreased harm. So as a sense of decreased risk goes down, the use goes up. And we've seen that throughout history. And that's one of the things that this slide is showing you is when kids think it's not a harmful drug, it's okay. And in fact, I take care of students all the time who will say to me, oh, it's like an herbal supplement. It comes from the ground. You could plant a seed. It's completely good for you. It's natural. It cures all problems. So one of the problems in this country is that we don't study marijuana use easily. To study anything in an effective way, you need a lot of money. And most money for big research comes from federal funding. And you can't use federal funding to study an illegal substance. You can use the marijuana that is grown by the federal government in Alabama on some federal field, but that's not what the marijuana is that any of us are actively using. And in fact, marijuana is particularly tricky because it's not really one drug. It's as many strains of a marijuana plant equivalent of a drug. And depending on how you use the drug, the way that it's brought into your body, you would have to study 400 different ways of ingestion with 400 different subtypes of marijuana to really know what it's going to do. So Australia and New Zealand are the two countries that do the best studies on marijuana use. And in one of the studies that I'm going to discuss, they followed for over a period of 30 years people who used marijuana early and then looked at what they looked like when they were 35 and 40. And what it showed was an 8-point drop in IQ. So starting marijuana use in adolescence showed an 8-point drop in IQ by the age of 35. This study here is from New Zealand, and it shows starting marijuana use early, so starting at 14 or under, which is actually a pretty common time for kids to start experimenting with marijuana, has a significantly higher rate of high school dropout, and then also a significantly lower rate of university admission scores. The other thing I'm going to say is for all the adults out there who use marijuana, quite honestly, adults have a developed brain. I actually don't really care if an adult uses marijuana at their leisure. I'm not going to have a strong opinion about that. When people say to me, look, I smoked marijuana in the 70s and 80s, one of my responses is, you have no idea what is available to our students these days. The marijuana that is available now is so much higher in THC. We have never seen levels. The stuff that people were smoking back in the 1970s may have had 1, 2, or 3% THC. People grow things now that are 20, 30, 40% THC, and then depending on the mode in which it's brought into your body, again, most people can't even identify this stuff in this picture. When I say the word marijuana, the average adult thinks of a rolled up joint. The average 14, 16, or 18-year-old may not even recognize what a joint is because they recognize it in these other forms. And these forms are able to intensify the concentration of the euphoric component of THC more than anything else. And in fact, that one that's on the bottom middle, which is what's called dabbed, sometimes called earwax, has as much as 70% THC. So we are talking a completely different drug than whatever you think you may have used in the 1970s. These are pictures that come out of Colorado, one of several states that have legalized marijuana for recreational use. And if you think they are not marketing this to teenagers, then I dare you to show up in Colorado and walk into any one of these stores. People with AIDS, cachexia, or end-stage cancer who can't tolerate their chemotherapy, they're not eating gummy bears with marijuana in them to manage their disease that marijuana may be helpful for. This stuff, Nutella or gummy bears with marijuana or pot tarts or any of these things are really intended for use for children and teenagers. And in fact, we've always been able to say in the past that no one's ever died of a marijuana overdose. But that's no longer true, because in Colorado we have at least 2 deaths of young children who've ingested edibles with marijuana in it. They're not intended for them. No one meant for that to happen. Yet for the first time now, we can say that marijuana kills people. So I'm going to again give a shout out to all of our teenagers out there who are making marvelous choices when it comes to nicotine use. And again, a lot of public policy went into this. Tobacco, paper tobacco products cost a lot of money. And so again, lowest rates of cigarette smoking. But one thing that's really gone up is the use of e-cigarettes. And e-cigarettes remain an unregulated industry. Teenagers will say that they have vaped or used something, and the truth is they will say they're just using flavors, but because it's unregulated, we have no idea what's in this mixture of they're putting into their vape machines. And so as cigarette smoking has gone down, the amount of vaping with e-cigarettes has gone up. And we're creating a generation that will start with this product, but when and if this gets regulated and possibly removed from the market, we're left with a bunch of teenagers now addicted to nicotine who will have to convert back to the paper cigarettes. So we're not doing anything positive in terms of public health by having e-cigarettes available. I'm also going to make one more comment on that, and that is that people want to believe that e-cigarettes help people stop smoking. The studies are pretty clear. They don't help people stop smoking. They may reduce the amount of cigarettes people are smoking. There may be some health benefits there, but until you get to 4 cigarettes a day or less, there isn't a lot of health benefit to having it replaced by an e-cigarette. So if it was really getting people off tobacco cigarettes, I think most of us would support it, but we have enough studies now showing it doesn't seem to work that way. I'm going to spend time talking to the parents that I'm addressing because parents have an enormous impact on their kids. And one of the ways in which we impact our kids is by making our own good decisions about how it is that we use drugs or alcohol in front of them. 1/3 of us in this country drink nothing. 1/3 of us drink a little bit, maybe a couple drinks a month, a couple drinks a week, what people will describe to me as social drinking. The final 1/3 of us drink the rest of the alcohol. And in fact, the final decile drink between 7 and 10 drinks a day. So 10% of us drink daily 7 to 10 alcoholic beverages. Now, most people don't believe me when I say that, but the problem is that it doesn't take much to get to that number. People don't really know what counts as one beverage. It's 1 12-ounce beer, it's 1.5 ounces of hard alcohol, or it's 5 ounces of wine. So in the limits there are 7 drinks a week for a woman and 14 drinks a week for a man before you enter into the at-risk drinking category. And so I just need everybody to pause and ask themselves, how much am I drinking? How much do I drink each day? How much am I drinking each week? Because one of the things that I will say is that there is a category of us out there, mainly people like me who are women who work and have families and complicated lives, who are drinking actually more than we've ever seen in history. Always used to be that the ratio between men and women with alcoholism was about 8 to 1. And that ratio is now shifting. It's more 7 to 3 ratio, because women are drinking more and more. And this has been a shift in the last 10 years. It's marketed to women. You have this sense of, I'm overwhelmed, my life is overwhelming, I work a full day, I come home, the house is a wreck, nobody's put the breakfast dishes in the dishwasher, nobody walked the dog, and I have 8 more hours of work to do at home. And women have this instinct of, I'm gonna kick back. And so when I ask somebody in my office, so how much are you drinking these days? They'll say, oh, I have a couple glasses of wine a day. And I'll say, how much is in a glass? Because we all know what glasses look like these days. And they're not your grandmother's wedding wine glasses. They are giant goblets. And women come home, and men too, and they glug, glug, glug a giant bottle of wine. So the point there is that it doesn't take much to get well beyond the 5-ounce serving, which is easily how you get to 7 to 9 drinks. The other comment I'm going to say is that if you can pause and ask yourself what happens to you after you've had a long day at work. You walk in the house, you've had a terrible day, your kids can see that on your face, and the first thing they see you do is go to the fridge and pop open a top of a beer or pour yourself a glass of wine. And what kind of role modeling is that? You've had a terrible day, your boss yelled at you, and you drink. So the message you send to your kids is when you're stressed, when you're miserable, turn to alcohol or turn to something else to turn it off. What if we all came home and said, wow, I had such a terrible day at work. Will you go walk the dog with me? I had such a bad day. Could you go sit in the other room with me and do 3 yoga positions because I'd enjoy your presence and I know that would make me feel better. We have to remodel healthy stress management tools and not just turn to substances to turn it down. So far I've covered 2 of the 3 things that predispose you to have the disease of addiction. And one was genetics, and we have no control over that, but at least we should all know about it. The second is early exposure. And the message I want to say to parents is that we need to advise people to delay exposure as long as possible. The final thing that predisposes people to a lifetime of addiction is to have trauma early in childhood. And I actually think most people are a little surprised when I launch into this part of the talk, but it's such a recurrent theme. And it's one of these unexplored entities, both in medicine and behavioral health, that I actually think that we need to get out of the closet. So we're going to spend time talking about a 2007 report that came out of Kaiser. And it's the Adverse Childhood Events study. And it was done in San Diego County by a team of Kaiser physicians, the lead author being a preventive health person who was studying childhood obesity and why it happens. And in this survey, they had 10 questions about what might have happened to you growing up in a household under the age of 18. And the results really surprised them. It was not what they expected. They took the data that they got and they then compared it to 40,000 Kaiser patients who had a lot of chronic disease. And what they found is if you scored a 4 or higher on an ACE survey, and I'm not going to read the entire survey aloud. If people want to study it, it's easy to see up on the screen. I actually think everybody should know their ACE score. I think it informs you about who you are and why it is that you might experience the world a certain way. What we know is that 22% of Americans have been sexually abused. And I think that's actually a shocking number. There's some studies that have it as high as 25%, but that 22% also of us in this country score a 4 or higher on this quiz. And if you score a 4 or higher on this, it puts you at high risk for a variety of chronic diseases. If this survey is measuring household dysfunction, neglect, and abuse, and it is a predictor for things that you wouldn't anticipate: asthma, COPD, heart attacks, early death, greater than 50 sexual partners. Specifically, it is a high predictor for having the disease of chronic pain, but also addiction. So we've covered these 3 things already, and what I would say to anybody who is raising children or teaching children or doing any work with students is you want to talk early and you want to talk often. Talking to your kid for the first time in 10th grade about drugs, it's way too late for that. I mean, really, you should be having these conversations with 5th graders. A kindergartner should know never to pick up a pill on the ground. They should rush it to an adult. But really, 5th grade is the time where you need to be having these conversations about why it is that you may or may not be at risk for this disease. And again, genetics, you explain to them what you're comfortable with, but as they get older, tell them the truth about what runs in your family, because there's not a family out there that doesn't have some genetic risk. The second component is early exposure. If our students can make decisions not to use tobacco, marijuana, or alcohol, until they're age 18, 19, 20, 21 is even better, until their brain is fully developed, you will have made an enormous difference in who is going to struggle with this disease. And the final thing is, again, acknowledging that the history of trauma makes a big difference for our students, but it also makes a big difference for those of you out there who have fully developed adult brains who've struggled with this, because getting treatment for your trauma is the most important thing. And numbing it up with opiates or with pills or with alcohol isn't the right approach. But it's the approach that we're most familiar with, because there's nothing that numbs up psychological pain more effectively than those drugs. But there's very good trauma-informed care out there, and that people need to access that. And more of our behavioral health people need to be able to provide that for people. Again, I want to give a shout out to the students of year 2015 and 2016. They're making better and better decisions. Our rates of alcohol use are down in high school. The rates of cigarette smoking are way down. Overall illicit drug use is pretty flat. But over the history of time, you find people being so condemning of what it is that our students do these days. The truth is, most of our students make fabulous decisions. And we need to celebrate sort of the norms that are out there, which is that most people don't smoke, most people don't use drugs, most people don't drink in high school. They make great decisions. But on Monday morning, you mainly hear about the Friday night post-football keg party, and you don't hear about the kids who were playing fantasy football or Dungeons and Dragons. And one of the things I would argue is it would really be great to celebrate the kids who actually define our norm, which is that they're making great decisions. And so for all of you out there doing that, keep doing it, but I wish that your voice was louder in our communities. So I'm going to shift a little bit and actually focus in on opiate misuse and abuse in our communities. I often will travel a place and they'll say, oh, this little town is the opiate epicenter. And I think to myself, every little town, every little county out there is thinking this way, because this is a widespread problem. And I don't care where you're hearing this from. I think that actually this is a problem in your community. For me, it began actually waking up one December morning, and every morning I get up and I drink my coffee and I start with the obituaries because I'm a local family doctor and my patients die and I kind of need to know who died last night. So that morning I woke up and I read the obituaries and it read, Ashley Sims, age 21, died of a heroin overdose at home. And I thought to myself, oh my God, I know Ashley, I know her grandmothers. And I also thought they were so brave telling the truth about how she died. And after that, because those grandmothers pushed it, they went to the newspaper and said, please tell the story about how our granddaughter died. And so in little local papers all over our country, stories began to be told about how it is that community members, neighbors, friends have gotten into trouble with an addiction to opiates, starting with prescription pills and then moving on. And so for me, sort of the public outcry started in our little local newspaper. Time magazine has on its cover that pills are on the line for our current epidemic. And I don't disagree with that. This did not start that heroin got cheap and easy to get. It started somewhere, and it was with the overprescription of prescription pain pills in our communities. Starting in the 1990s, pain is the fifth vital sign became common language that was used in our hospitals. It was part of the evaluations that hospitals had. It was part of the patient evaluations of emergency rooms, is how well was your pain treated. And the cornerstone of the pain management movement was one of two things. There was a letter to the editor in the New England Journal in 1980 saying that chronic use of opiates has a very low rate of addiction. And the second was this article I'm showing you here, which came out of Sloan Kettering and was published in 1986. And it had an N of 38. So 38 patients were studied with opiates over a long period of time, and they didn't have cancer and they didn't have acute surgical pain. They were being treated with chronic opiates for non-cancer pain. And in this study, 2 of the 38 became addicted. And so again, a tiny little study that supported the use of opiates for osteoarthritis, migraines, fibromyalgia, other diseases out there, with the implication that people wouldn't actually get addicted. What we knew or didn't know at the time, but what quickly unfolded though, is the more we prescribed opiates, the more people died of opiate overdoses and the more people entered treatment for opiate addiction. And I would argue that we should have known this. I mean, this is so predictable. In the 1990s, really a kindergartner could have drawn a graph like this. These are powerful drugs. It is hard to keep them safe from other people who might want them. And they're drugs that will make you feel numb and high and happy for some of us, and they're drugs that people would want to get their hands on. So half of all opiate prescriptions in this country are given for non-cancer or non-acute pain, so they are heavily prescribed for those reasons. This is a graph that shows the decade prior to this, looking at where it is that public health has done a great job at reducing death between the years 2000 and 2010. And in the areas that we have reduced death, you'll see that we've done a reduction in aortic aneurysms. And the number one reason for that is we've reduced smoking. Smoking is the number one cause of why it is that somebody would have an aneurysm. You also see there's been a reduction from motor vehicle accidents. I think everybody knows why that is. We use seatbelts more often. We have safer cars. We have airbags. You see that there's a reduction in influenza and pneumonia. That's because people are getting vaccinated. So there's areas where we've made a reduction in death. They're mainly due to public health measures. And in those areas where we've had an increased rate of death, most of those diseases are related to getting really old. You see that Alzheimer's has gone up, Parkinson's has gone up, nephritis or kidney failure has increased. And it's not that we have an epidemic of Alzheimer's, it's that people get really old. They get to live a really long time and eventually something's going to get you. So most of those diseases that you see that are on the rise are related to the fact that people get old. There's 2 things there that I am going to comment on. One is that suicide has increased. And the second is that line that nearly goes off the chart, and that is that we've had a 276% increase in overdose from opiates. And if that is not a picture of how it is that we have made a major public health crisis from our overprescribing of opiates, I don't know any better demonstration to that. This was brought to you by the American medical system. This is not something we've seen in other countries, and it's something that we need to fix. This is lovely graphics straight from the New York Times that shows what overdose rates look like throughout the country. And it starts in the year 2003. And as you march yourself across the screen from left to right, you begin to see red areas light up. And initially in those top maps, you see that Appalachia lights up. parts of the southwest light up. And as you head into that second row down, you start to see a lot more of the country is turning red with overdoses. You start to see that New England in the Northeast starts to get some orange areas of increased rates. You start to see Appalachia expand into the Rust Belt. And by the time you get to our current present time, there is a lot of red. There's a tremendous amount of overdose due to opiates. All of the Northwest, the Southwest, most of the Northeast, Florida. Very little, just that central part of the country has been left unscathed. In the New York Times, preceding those maps I just showed you, was a really interesting study that came out of two researchers from Princeton, looking at where it is that people died and where it is that we've been seeing an increase in death rates, things that you don't expect. In fact, you always expect death rate to go down. We're the richest country in the world. Theoretically, we have certainly the most expensive healthcare system. And in fact, every year our death rate should go down, right? But what they found is that the death rate was not going down for one category of people. That white middle-class individuals, especially between the ages of 45 and 55, were dying at much faster rates. And at the time that this came out, they didn't have a great true explanation, but they thought, wow, maybe this is related to suicides, addictions to alcohol and opiates, and maybe it has something to do with the economic downturn that was experienced in 2008. Further digging on that, and the New York Times again did great research, actually looking at 600,000 death certificates, really laid most of the blame of that increase in death rate at the foot of an opiate overdose epidemic. So I personally feel responsible for this epidemic because I'm a doctor. I know I'm not actually personally responsible, but I was in practice during the time that a lot of overprescribing happened. What we know about New England, which is where I trained in practice, is that most of the drugs that came to New England didn't actually come from prescription pads of local doctors. In fact, I-95 was known as the Oxy Highway, and that the vast majority, in fact 90% or more of the oxycodone that was brought to New England came straight to us from Florida. Oxycodone, 90% of it that came to New England, it came from Florida. So at the time, in the early part of the 2000s and well into 2010, 2011, there would be tour buses that would come down from Ohio and Kentucky and Maine, and you could have your way paid on a bus down to Florida, and you would have 2 nights in a hotel, and you would have your meals paid for, and your job was to walk into one of 900 pain clinics that were set up in strip malls all over Florida. And you could walk in with a limp or not a limp, it didn't really matter, and you asked for your pain pills for your arthritis or your migraines. And these places not only wrote prescriptions for pain pills, but they dispensed the drugs. So you'd walk out with a bag of 300 pills and a prescription for another 300. Your job was to collect the stuff, give it to your tour bus operator, and then go back to your home state. You weren't dealing this drug on the street, but the tour bus operator was. And it's one of the reasons that all of these drugs came to all of our states. And in 2010 and 2011, the federal government looked at the state of Florida and said, if you cannot get your drug problem under control and stop roping every other state in on this, we are going to shut off all federal funds. You won't get highway funds, you will not get education funds, you need to fix your problem. Florida really perked up and listened at that point. And they, by 2011, had shut down many of their pain clinics and had incarcerated 37 doctors who were American licensed physicians who actually were basically drug dealers, making millions of dollars on the backs of people who now developed an addiction. Now the problem is when you shut down all the pills that were coming to these states of Kentucky and West Virginia and Ohio and Maine and Massachusetts and Vermont, and there's nothing left, then what's going to take its place? People were watching. The Mexican cartels were ready for this, and they had really good quality, pure, and incredibly inexpensive heroin ready to take its place. So as the heroin purity has gone up, the cost has gone down. Depending on where you live, the price may range from $3 to $6 a bag, depending how far you are from the distribution site. When you ask emergency medical workers what the #1 drug threat is in their community, what you see here is that in the Northeast, they'll say the #1 drug threat is heroin. And they'll say that in the Northwest as well. What's interesting is they actually don't say that in the Southeast as much. And I want to talk to you a little bit about why that is. So Massachusetts opiate overdoses have gone up. I could show this graph of probably every state out there and have the same overdose rates continuing to spike. And what we know now is they're not yet in decline. In fact, this year looks worse than other years. What this map shows you is the dark purple states are states where there's still a tremendous amount of prescriptions of opiate drugs. So in those purple states, their averages between 0.86 and 1.4 prescriptions for an opiate per person in that state. So last year, it means everybody in those purple states received at least one opiate prescription, sometimes as much as 1.5. Now, we know that's not really true. It means that some people may have gotten 24 or 36 prescriptions, but on average, those are states where opiate prescribing still happens at a very large volume. What you see next in this map is where heroin is the #1 problem. And so the Northeast lights up, the state of Illinois lights up. And if we can go back to that other slide, if you could imagine when those purple states start to have their pipeline shut down of their prescription pain mills, when those places start to get shut down, those purple states are going to turn into red states. They're going to be places where heroin is the #1 problem. And those are states where I don't anticipate there to be ready access to Narcan, where there'll be great public education, where there'll be excellent treatment on demand for people who have addiction. And instead, what I anticipate is that tens of millions of Americans are going to die of heroin overdose. One of the things I want to say to parents in the room is that there are times in your adolescent's life where they're likely to get exposed to an opiate. And I want to think about this for a minute. For athletes, they get injured. They may have an ACL tear, they may fracture a femur playing hockey. So it is often with a severe injury, they will be prescribed an opiate. The other time that is most common to be prescribed is with the removal of wisdom teeth. So wisdom teeth often will come out between the ages of 15 and 21. And then also an appendix is another common surgery that might happen during adolescence. So I'm thinking about 3 common times where a teenager may be handed a prescription for an opiate. So here I have a young person with a developing brain, and we know that early exposure is bad. And the message I want people to hear is that, one, an adult needs to be in charge of the medicine, and you need to use these medicines as carefully as possible. That the combination of Tylenol and ibuprofen alternating for most people works extremely well. There's studies that show that it works as well as a low-dose opiate. And I'd want you to talk to the prescriber and say, how can I use less of this strong medicine? I'd really like to use other things. Can you tell me how I can use Tylenol and ibuprofen to help reduce the pain? The second thing is to get the smallest prescription you possibly can. If they offer you 30, say, I don't want 30. Can you give me 4? Because when you ask most people how much pain medicine they used after dental surgery, they often will say they used 1 or 2 or 3. And why it is that anybody is writing for 30 or 60 of anything anymore. And then the final thing is that kids cannot be in charge of their pain medicine at home alone. I can't tell you how often I take care of a 22-year-old now who has a heroin problem. And I'll say, when did you start? And they'll say, I got my wisdom teeth out and I was home alone with my bottle of Roxicet, and I've never felt so good in my entire life. And I finished that first bottle, I called the doctor and I got another one. So we all want to reduce this disease. We want to reduce it in the earliest years we can. So controlling when it is that our kids are exposed, we all have control over that. So for those of us who have kids that we're raising at home, or grandkids or nieces and nephews that you're trying to pay attention to, one of the things that happens all the time in my office is the parents will come in with a kid who's now using heroin and say, I had no idea it was happening. And I just want to list what some of the common signs that you might see at home. I mean, when people are using drugs, initially they may be kind of sneaky about it, but after a while they let their guard down and they start to get clumsy about their use. So if any of these things you're seeing at home, you need to pay attention. One of the things I'm going to recommend is you actually walk into your kid's room, which I think a lot of us who are parents of teenagers don't want to go into our kids' rooms. My kids' rooms are a mess. They smell bad. I'm mad every time I walk into their room. It's their problem. It's not mine. But I tell you, you've got to actually go into your kid's room to see if you're looking for any of these things. Because some of the things I'm showing you in the slide are things that you should never find. I mean, loose pills being in your kid's room, actually a bottle of Tylenol or ibuprofen really shouldn't be under your kid's control. One of the #1 causes of liver failure is teenage girls using too much Tylenol when they have period cramps. Like, they shouldn't be using that medicine without talking to you. If you're finding burnt foil, there's never a reason to have burnt foil gum wrappers or tin foil. There's nothing that would have any reason for that other than drug use. A bent spoon would be very worrisome. anything that's rolled up. Here it's showing you a rolled up dollar bill, but sometimes the insides of a pen, a broken pen, you can snort crushed pain pills with that. Some of the other things that you're seeing on this slide are things that are filters. So cotton balls or Q-tips or actual filters that look like cigarette filters. People will inject through a filter to get rid of some of the contaminants. Anything that could make a tourniquet for your arm so it's a little bit easier to inject. So here there's a picture of a belt, but sometimes people will use an elastic or they'll actually have a tourniquet from a phlebotomist. Some of the other things that you're seeing on this slide is a straight edge razor. I mean, first of all, razors shouldn't be in your kids' rooms. They're not glazing the windows. They're either going to be cutting themselves or they may be using drugs. So those things need to be gotten out of the room. So I do recommend people go through their kids' rooms. When parents do, after their kids are brought in struggling with an addiction, they'll tell me the number one thing they find are thousands of those little either plastic or wax baggies, because kids use them and they're underneath the bed and in the mattress and in the sock drawers, and they find them everywhere. One of the most important things we can do when we're struggling with a family member or loved one with an addiction is to actually keep them alive long enough to get them into treatment. Addiction is a terrible disease, as we've talked about, because it really does hijack the brain and it hijacks the decision making of the brain. And really, people can't get better until they really want to get better. But in the meantime, we need to help people stay alive. And naloxone or Narcan is one of those tools that actually those of us who have people that we are worried about, we need to have access to it. So there's two great websites that I'm going to recommend people go to. GiveNaloxoneNow.org is a great website that I think you could go to, watch a video on how to administer Narcan. The other one is Prescribe to Prevent, which is another very commonly used one. There's YouTube videos that you could also just look up. The tricky part about naloxone is actually the assembly. So it does come in a spray that's already assembled. It comes in a shot that's easy to use, that talks to you. But the most common way that it's dispensed is as a little syringe. And so actually knowing how to assemble that and use it is pretty critical. So if you have a loved one that you are concerned about, you really should have this and know how to use it. And you can ask your doctor for a prescription, although in many places you don't even need a prescription for it anymore. So if you've enjoyed this, if you think to yourself, wow, I really would like to learn more, I'm going to recommend 4 books that I've read recently that I thought were really remarkable. You could read any one of them and get a lot out of it. If you're interested in addiction overall, particularly addiction and trauma, I think that Gabor Mate, In the Realm of Hungry Ghosts, is an extraordinary book. He's an extraordinary writer. The book that I've liked the most on trauma and recovery is The Body Keeps the Score. It's a marvelous book, beautifully written. And I think anybody out there who's heard this and is now exploring in their own lives or people that they love a history of trauma, I think that's a wonderful book to read. I think the book on Chasing the Scream is really going to open up your mind a little bit about sort of the failed effort of the Just Say No to Drug campaign in this country and in Western Europe. I think there's other models out there, and I think he does a pretty good job of explaining it. And then Dreamland is a book about how smart the cartels are about getting this drug into our communities. In that their model actually is not a particularly violent model. It's a really high-end, high-tech business model. And shutting down the pipeline coming to this country is going to be a very challenging thing to do. So if you want to learn more, I would go to the library and get out any of these books. They're all excellent. And I want to remind people, because I think sometimes when you're talking about this disease, it feels hopeless or like the brain is broken and you don't get better. But the truth is people do get better. People get better in a variety of ways. There's many paths to recovery, and you often have to use them, several of them all at once. People ask me all the time, do the dopamine receptors come back? Do you get to make dopamine again? And you do, because what matters the most with recovery is length of time in recovery. That places that will boot you out after 5 days or after 30 days, you've got nothing after 30 days. You're just starting to get your head cleared out. People start to feel like themselves after 3 to 6 months, but the rates of relapse remain very high underneath 12 months. And really, it's when you're at 15, 18, 24 months that your life has really come back together. People need long-term, structured, sober living options where they can get better with a variety of therapeutics coming their way. And what builds dopamine? Having human connections, falling in love with people, having a purpose on this planet, feeling like you're giving back, having a job, growing things in your backyard, exercise, meditation, things that are healing. So locking people up in a cell for having the disease of addiction isn't making them better. And they're going to get released one day, and they're going to be your neighbor and your nephew and your son back on the streets again, not much improved. So we actually really need to get treatment for people with addiction, and we need to be cognizant of what it is that's going to help them build over a long period of time their dopamine back to normal levels. So thank you for sitting here and watching this. Remember that people get better from this disease, that recovery is very possible. It takes time in recovery. It takes people in recovery helping others in recovery. And spread the word about this message. Educate people in government, educate people who run insurance companies to help change the practice of how we manage people with addiction. Thank you.